Hello everyone. So this is Charlie. He's one of my F2s. He's agreed to do a tutorial. Well, some of it recorded anyway. Yes. So I think today was about to start a tutorial, and we got disturbed, which sometimes happens. I was about to call Charlie, and I see a patient. Charlie was already trying to help the reception staff, which was it's really touching. It's really nice, good feeling. It reminded me, when I used to get stuck in there, which I still try to do as much as I can, but
Busy man these days.
So Charlie, so tell me, run me through what were you actually doing? Because I thought it's quite nice to just talk about some of these sort of additional things that we take on top of what we're already doing. And sometimes we can't always be prepared and deal with what's planned, what's in front of us. We plan for a tutorial, we plan for 4 patients or 5 patients in our list. But how did you feel when the reception staff actually found you quite receptive and came to you for some advice? What did you say? What did you do? What made them come to you? Is it just out of interest?
I guess they come to me because I'm new. I don't like saying no to help, not help with anyone. So there was this quite elderly lady who only speaks Spanish. I had a consultation with the other doctors here a few weeks ago, and she's type 2 diabetic, but it's quite poorly controlled. And she had quite a high reading on her blood test. HbA1c was about 11.7, I think, which is quite high. And basically, she'd only booked in with the nurse to have another blood test, but I think that was a mistake. But just ad hoc, we just decided to quickly see her and talk to her about it. So we had to get language line on the phone, so it ended up taking quite a lot of time. But for her, it was a big issue, because we also found some other things going on about low mood and potentially her being homeless, because her children are moving back to Spain. So we took some time out just to go through all of these things.
So I found it quite, it was actually a good case, because the ladies, when I saw her high sugar levels, and suddenly just jumped from very good to worse and much worse. So when you saw those results and the hurdles of language barrier, what came through your head? Did you feel you could do, or is there anything in particular that you felt at the time? Or?
It's quite challenging, especially someone just beginning English at all, because even through the language barrier, it takes quite a long time. So obviously there's miscommunication, and the translator say things differently to what means something different in Spanish. So it takes a while to get an idea of why her diabetic control's been off for the last few months, and we still weren't really sure. We think it's because she's got very low mood recently, and then she's been eating differently, and the added stress, and stress can obviously affect sugar levels as well. But it took a good sort of half an hour to get to the bottom of that. So it's just an added problem with someone using language line.
So,
you just have to take time, don't you?
Yeah, going through her case, I felt it was a good sort of challenge that we see day to day, maybe not always, but as you said, she suffered with low mood. With diabetes, and she's on insulin, right? And do you think she was there anything? What were you thinking of doing? Because I know Charlie likes to, he's quite prescriptive, in the sense that you want to take the bull by the horns and deal with it and give her medicine and sort the problem out today. But how do you see, where she's going? Do you see her, getting better? For example, do you see her overcoming this poor control?
I think she can, yeah. 'Cause I think quite a lot of her poor sort of diabetic control maybe down to dietary and lifestyle reasons, which she didn't know before. But she wasn't really testing herself that often often during the day. She's only doing it really in the morning after she'd eaten food, so obviously that would give high readings, artificial high readings anyway. And then she wasn't taking her insulin before meal times, as with the metformin as well. So we just increase the insulin a tiny bit and then give her some more advice about how and when to take it and what would be most effective. So rather than just adding in a new drug, which I was keen to do, we'll just see how she goes with like better regimes, as it were.
So,
And then,
do you find that's a good management plan when you talk about how she's doing, taking her insulin, for example, how, you know, if it's in the right side, or, you know, general, like, knowing when to take it, when to take the medications, and rather than just giving her more medicine? I mean, for me, obviously, as a GP over so many years, it's quite normal to not just jump and do all that. But like for you, coming from hospital, like, do you feel like we're doing, you know, as a GP, do you think this is important, or how important would it be for her? From her,
I think it's really important, especially as you get older. People tend to get just piled out the medications that they have. You kind of polypharmacy, whereas in GP, I understand a lot of it can be due to the way they take the medicines and how good they are taking the medicines, and looking at the long-term thing, try and reduce the amount of medicines they take. But I guess in hospital, when you get told by your consultant or your reg just to sort a problem out, obviously you don't have like a few weeks to wait and watch and then come back and see how they're doing with sort of lifestyle and the regime sort of tactics. They want you to give like an instant show of how it's come down by like so and so level in like so much.
I understand. Yeah, really, it's one of the differences we have. But I mean, we work hand in hand. So, but I was flicking through the diabetic clinic referral letters as well. So, which kind of helped me in some sense, because they were also not keen on giving more medication. So going through that consultation, take me through what else, like step by step, that you know that you encountered, and what you know, was there anything else that you felt, or the management plan, or you felt that you added, or something that you changed, or just take me through the consultation a bit more in depth.
Okay.
Probably. What I mean is you talk about her low mood. Was there other social things that was worrying you, like the social side of things, like, because that's a big impact it's having on her.
Yeah. There's also the homeless issue as well in a few months' time, because she's probably moving back, she might be homeless, and that's just added stress, isn't it? Which can affect her, sort of the way she takes the medicines, whether she forgets to take them, or how good she is at keeping to her regimes. As we mentioned, obviously stress can make sort of blood sugars higher anyway. So we try to refer her to, it's tricky, isn't it, because when you're trying to do consultation about sort of mental health and stuff, it's quite hard to really get a grasp of how they're feeling when there's like a middleman, as it were, who's translating everything that you say. And obviously when you speak to someone who's fluent in your language, you can pick up on like the words they use, like the tone of voice and stuff like that. But you can't really, it's hard to get those cues, isn't it, when it's via a phone.
Yeah. But she seemed quite happy and with you, and you know, with the plan, and she was very happy to have met you from the sound of things, you know. So I think you didn't do a bad job in that sense. Like, she felt empowered in the sense that she took on board a lot of things. I felt like she was generally quite happy to have come in randomly today, just booked with the nurse, and then suddenly seen the doctor, booked in for another blood test for some reason. So obviously things are making a bit more sense for her, and maybe seeing things a bit clearer. Maybe she said something about not having any not knowing what to do because her daughter's leaving for Spain and her son's leaving her, so that can be quite scary.
No, I can imagine, yeah.
So, I mean, going back to her, so she's going to be seeing you now in 3 weeks' time. What do you think you can add to her care now?
So, in 3 weeks, hopefully, we asked her to do like a more strict sort of diary of what her blood sugars are. So then she can have like a few weeks worth of what all her readings are, so we check for like hypos or how high it gets in the evenings. And then so with those it gives a better idea of how to control her from a diabetes point of view. But we're also, in that time, we do a referral to IAPT, which is the talking therapies, and hopefully they'll be able to work something out in terms of, I'm not sure if they do language barrier consultations. I think they do, don't they?
They do, but she might have to go elsewhere.
Elsewhere, yeah. So we'll have a look at that and make the appropriate referral. And I'm going to write a letter to the council as well to try and get some appropriate housing in time for when our children get back to Spain.
So you've taken on a lot of work, and you know, obviously this is a patient that you didn't foresee in your list. I mean, obviously she seemed, you know, she was really grateful, and you know, so I mean, for me it's quite nice and refreshing when I see patients are making differences and are making changes. And Peckham, we get a lot of patients like this who you can actually do
make
something
a
about.
difference.
Yeah, so
yeah. I guess if you think of from her point of view, like her situation at the moment, it would be really scary, wouldn't it? Because she's currently living with her children who I think they speak English, and obviously she doesn't speak any English at all, just speaks Spanish. So for them leaving and then being people that support her and she's going to be left without a home, maybe without any support, it'd be a scary thing. So obviously I'm happy to take some time out of my day just to try and make that easier for her.
I think that was the first time she's come herself with me as well. So,
Yeah, it was.
so it's quite scary in that sense. And,
Mm.
so the housing letters, generally as GPs, we do charge for all our letters because it's extra work. And now you're understanding a little bit more about how the NHS practice and how everything works. And sometimes we do charge her. I mean, how would you feel about charging her for the letter that you're going to do for the housing?
I wouldn't charge her, definitely. I wouldn't charge most people around Peckham area because obviously a lot of them are struggling with money or on benefits as it is. So it's a bit of a kick in the teeth that they come and try and get help and then you charge them for the help that you're giving. It doesn't feel right, does it, I guess?
But how will it feel if you get a lot of these requests, which most of us do get, at least a few a day, and that increases your time, your, I guess what I'm trying to say is, how would you decide on, who to charge? Because then you might increase our workload as well, for certain patients who might be able to afford it.
I guess you have to get to grips with their situation, how things are financially, how they're coping at the moment. Like some people get the feeling that if you, even if they didn't really need a letter for something, if you said unfortunately you have to pay for it, then that would just break sort of the connection between the doctor and the patient, and they would just go away and not get that problem looked at.
It's very important because I think I felt we kind of like won her rapport, her trust, and in Charlie, I don't think she has. I'm not sure if she has any resources herself to afford a letter. So I think yes, you have to be quite, choose. But it's quite tricky because we do say a blanket. So I think in this one-off, I think it's quite important that we go and maintain her trust and try to help her. I mean, she's on insulin and she's homeless. That's in her best interest, so we have to look after her best interest. If she's out in the streets, not having a fridge to put her insulin in, having needles where she's gonna degrade the public as well. Safety. I feel it's important that we give her something, like a letter, without even asking for.
I agree.
But yes, I agree. So taking a deep breath and relax. New sort of mindful thing I do is 3, 4, 5. So taking a deep breath and then hold for 4 and breathe out. Let's do that. Are you ready? Okay. And blow out. Feels so much better. Lightheaded as well. Okay. So I think so. When you're going to see her next, I think we're going to do the DM charting and we increase the sugars. I mentioned something about linagliptin. Have you heard of that medicine, that particular medicine? There's been quite a few new diabetic medications recently.
I've heard of it, yeah, but I wouldn't say I know too much about when you'd sort of jump in and start that rather than the other.
I mean, you mentioned glycoside too, because you wanted to start something and you felt maybe glycoside.
I think that's only because I've seen other patients with type 2 diabetes on a combination of glycoside and metformin. As I said, my knowledge of like sort of more complex diabetic patients isn't the best.
But I think she's more complex. She's on insulin already, and she's on metformin. So you're taking on a patient who's already quite complex, high sugar levels, and you know, and then it's quite hard to just follow guidance like metformin, but step by step guidance is quite tough. So adding a glycoside already, I mean, you asked already for hypos and she was not getting hypos, so it could be reasonable, but I think we tend not to always add glycoside with insulin.
Okay.
Sometimes maybe modified release or maybe a reduced dose could possibly help. But I was thinking maybe linagliptin or sitagliptin. Renal function is good, and the functionality with the gliptins generally increases insulin, so it sort of mimics incretins, some sort of hormones which sort of mimic insulin and help reduce sugar levels, but at least close to percent HbA1c. So she's at 11%. It's not going to be great, it's still be 10%, but I think with all the other things it might help her in the future. It's got less side effects.
Okay.
So something maybe we might consider.
Yeah.
So I mean, I think we covered most of it. I think, is there any other questions you have on her, or because you were seeing her?
Not really, no.
Would you have done all those health those yellow boxes that said foot check and other diabetic checks? If you have done that, it took us, what was it, 40
Would you have done them myself?
today? Would you have?
Probably not enough time, is it, unfortunately, with the language line as well. The next time we've got a double appointment booked, so hopefully that will be about 40 minutes, 50 minutes. There should be enough time to do a comprehensive check-up.
Yeah, so I think it's good to also involve the nurse and put in the nurse as well, just to go through the diabetic health check as well.
Okay.
Come to think of it, she might need a double appointment as well as a nurse because it's a language line patient, and she was quite tricky. So we have to look after our staff as well, and as well as help patients. So I think that was a nice just reality check in the sense that we get to we have to be quite flexible with our patients. Okay, let's take a break from recording, would you say?
I don't mind, it's up to you.
Yeah?
What
I think that should be fine.